Hi people, welcome back. This is the last session of recording for the September paper 2 mock 13, questions number 11 to 14. We have already recorded the other questions and I have shared the details with you all. For all the new people who are watching this video, how to study for ADC part 1, read therapeutic guidelines, read infection control, read ODL after you're done reading at least twice or thrice. Then take my mock 1, solve that. After solving that, read the feedback. And after reading the feedback, go to the YouTube links that I've posted explaining the questions and how I reached a particular answer. That's called as analysis of the question. See, ADC is interested in knowing how much you as a clinician can analyze a particular scenario and make the right decision. Okay. They are not testing your knowledge of dentistry. They are testing your knowledge as a clinician because you are not giving their graduation exam. You're giving their exam that you're qualified to practice as a clinician. Understood? So here the main importance is analyzing the question, not jumping to answer the right answer. You get my point? They are not testing your dental skills. They are testing your clinician skills. So, okay, all right. Let's go ahead with the question number 11. A 41-year-old patient who was aware of grinding his teeth during the day when stressed. Alright, so he's grinding the teeth when he's stressed. He was struggling to chew as he was missing so many teeth and was concerned about the wear on his remaining anterior dentition. His slightly reduced facial height. Now see, when teeth get treated, the facial height gets reduced. He felt that over the years his nose was getting closer to his chin. That is a classical sign of decrease in vertical dimension of occlusion. Alright. So now they have presented us two pictures. Now when we see the first picture, we see there is a classic deep bite. So in a deep bite, what happens? The lower anteriors will hit the roof of the mouth, that's the palate, and the upper anteriors are hitting the lower gums. Now, suppose this picture was given in a child around, say, 8 to 9-year-old. What would you be doing? You would be giving an anterior bite plane, correct? Because what does an anterior bite plane do? It will create gap in the anterior region and the posterior region so that the molars can erupt. That's how the vertical dimension of occlusion can increase. Now, we don't say anterior bite plane in an adult. We say that as a dal appliance, okay? If you have to Google dal appliance, it looks like this. Do you see? It can be given in anterior, upper or lower teeth. And when you give this appliance, you see out here, the molars, or this is a very good example. For example, just focus here. So they have given a dals appliance which is the same color as the teeth, probably for aesthetic reasons, or you can give a plate like this. You see the molars are not in occlusion. So what happens now? The molars will erupt. They will supra-erupt, and when they will erupt, the vertical dimension of occlusion will increase, and automatically the upper anterior, which were like hitting the lower gums in the anterior region, will not hit more. Understood? So that's the concept of the dals appliance. Let's go back to our question. Where is our question? Yeah, here. So yeah. So here, because constantly the lower gingiva is getting traumatized by the upper teeth, there is gingivitis or periodontitis developing depending upon what the scenario the next questions would be given to us. But there is trauma. That is the main concern. Understood? So let's see what is the first sub-question. What is wrong with the periodontal tissue around the lower anterior teeth? There is labeled periodontal trauma, as just I explained. There is no mention by the patient that he feels sensitive. He just says he grinds his teeth a lot. So answering the question as sensitivity issue is wrong. The pulp may have calcified because it's been a long time, and since the question has not mentioned the main question, there's no mention of any pain, So I will go with label periodontal trauma, because what is wrong with the periodontal tissue? This question is also asking. This question is not asking what is wrong with the teeth. It's asking what's wrong with the periodontal tissue. So the candidate has not understood this question properly and hence answers sensibly. So you see, it is so important to read the question properly. The question is asking about what's wrong with the tissue. They are not asking what's wrong with the teeth. You understand? Now, how to prevent further soft tissue damage? So first of all, why the soft tissue damage occurred? So, beautiful thing about this question is, say example, even if you had attempted the first question wrong, the second question is still giving you a hint that the answer has to be in the soft tissue. It cannot be a sensitivity issue, because this is now this is asking you how to prevent further soft tissue damage, because this question is assuming that you must have answered the previous question properly. Got my point? So, how will you prevent it? Well, you will prevent it by restoring the tooth with the composite and increase the vertical dimension to prevent further periodontal trauma. You cannot shorten the upper crown. That would be like drilling the tooth and making it short for no reason, because again it would keep hitting and hitting unless you correct the vertical dimension of occlusion. Next, the posterior teeth can be replaced with. You can go with implant restorations, but implant becomes a specialist specialty. You as a general dentist are not expected to place implant, and here the option is not given of referring for implants. Plus implants are very expensive and 10 other things need to be done with it. So as a general dentist, when ADC is asking you what is the best thing that you can do, you should answer a cobalt chromium denture, because that's the best in RPD. If that option is not given, you can go with the acrylic denture. Understood? Now, what is the Dahl technique? Dahl technique, as I was explaining you earlier, it causes a bit of intrusion of the anterior teeth and extrusion of the posterior teeth to increase the vertical dimension of occlusion. If you want to read more about the appliance, pause the video here, go to Google, see the images, read the explanation so that you have an image of the appliance in your head. So in future, if a similar question is asked, you are qualified to answer it. Diagnosis and management planning. Okay, if the Dahl approach is used to manage the occlusal vertical dimension, a dash, that is how many months would be required to allow relative axial movement of the teeth to re-establish the posterior contacts. This you will have to learn. It would take around 3 to 6 months. You cannot use logic for this. This is the normal time the teeth would need to move and maintain themselves in the axial relationship. Next SBQ. A 52-year-old male presents with disclosed restoration in his hand. So basically he had restorations and they came out and he got them on the palm of his hand, which is covering the area between the right premolar to upper left premolar. Okay, so probably such a big restoration means a bridge must have come out, The patient stated that he cannot chew anymore and he's seeking help. The patient began his initial dental treatments about 4 years ago due to extensive caries lesion on his remaining teeth. So he had a lot of caries and initial treatment had started around 4 years ago. But he was unable to complete the treatment and developed further carious lesions on the mandibular posterior teeth. Fair enough. The patient was recently treated with extractions of the mandibular posterior teeth through emergency clinic and was advised to seek definitive care. Definitive means a long-term solution. He has controlled hypertension. So because it's controlled, he's as good as a normal patient. Now, after examination, he found that the anterior abutment are fractured, recurrent caries on maxillary left premolars, recurrent caries again on maxillary canines, and generalized mobility of the maxillary teeth. So basically, instead of giving this entire big scenario and wasting your time, the precious time in the exam, the question basically just says the bridge came out from the anterior teeth and there is secondary caries present in the maxillary teeth and they are also a bit mobile. There were mandibular teeth present but they were extracted and the patient is having a controlled hypertension. They could have all summed up in 2 lines, but they want to give you a big scenario to trap you, to confuse you. Don't get confused. Read between the lines what is necessary, That is called as observing the keywords. Very important in the exam. Now they have given this picture where you see these are all like kind of root stumps and probably a bridge was there which came out, and that is in the hands of the patient, and the caries present behind probably are all wobbly. There are no mandibular posterior teeth. There's kind of an over eruption of the anterior teeth, So now, technical failures in connection with fixed prosthodontics are often caused by fatigue fractures. So basically what the question is saying is that when there is technical failure, usually it's caused because of overuse of the appliance. Now regarding the fatigue fracture, which of the following statement is incorrect? I know at first shot when you read this question you are like, what? And such a big scenario is already going in your head, and suddenly the question is on fixed prosthodontics. So it's a simple question. See, basically they're asking you when the fracture of the bridge is because of over or excessive use, which of the following statements is incorrect? So we have to find which statement is wrong. So the abutment, cement and reconstruction are all subjected to stress caused by the occlusal forces. That's a correct statement. So that's not our answer. Fatigue fracture may occur at the weakest point or where the maximum stress occurs. The weakest point is frequently in connection with the endodontically treated teeth restored with post and course. Well, you can say that as a bit correct. Third, non-axial forces are a risk of fatigue fracture of teeth, cement and restorative material. True. See, non-axial forces means what? What are axial forces? The axial line is basically like perpendicular to the tooth or parallel to the long axis of the tooth. Now, when the forces are coming in diagonal areas, for example, the tooth got tilted or lateral forces are coming, that are more detrimental to the cement and the restorative material, because compressive strength is higher in restorative materials, but the tensile strength often is not. Tensile strength is basically two things rubbing against each other in if you rub your palms facing towards the roof, that is called as a the tensile strength. Compressive is when you are, say, banging a desk with your fist. That's a compressive force. I hope the difference is clear. So lateral forces create a lot of tensile strength, which the restorative materials are not so strong. Favorable occlusal prosthesis design is probably less important for survival of structurally compromised endodontically treated teeth, and that is a type of post-used. This is incorrect. This is an incorrect statement, because favorable occlusal prosthesis design is very important. It's not less important. It's very important. Understood? That's why this becomes the answer of choice. Now, ferrule. A question on ferrule, guys, is going to come like 90%. They love to ask you what a ferrule is. They want you to know what a ferrule is. What is a ferrule? A ferrule is a sound structure of the tooth, at least 2 mm in diameter, like overall, upon which the crown should be placed. Your crown cannot be on the restorative material. See, example, the tooth was fractured, you placed a post and you placed you do a core, but the core is made up of the cement or the restorative material. So what you have to do is you have to dig a little down, and you have to give a circumference of the sound tooth structure. Basically, it can be on the root, it can be on a deeper section of the clinical crown, but the margins of the crown has to be on the sound tooth structure, and that is called as a ferrule. You can also give crown on the restorative material itself, but then it would be more prone to fracture along with the post. The crown can get debonded easily because it's not resting on the sound tooth structure. Hence, a ferrule becomes important. So what is ferrule? So all these definitions which are given, A, B, C, D, all are correct. Hence, the answer is E. Now, on the endodontically treated teeth with varying degrees of ferrule, which is what is the correct statement? That is what they are trying to ask. So, in the non-ferrule group, root fractures were predominant. That is correct, because when you don't give ferrule and you just put the crown over it, the root fractures will be dominant. So that's the correct answer. When an edentulous space is maintained without a replacement, restoration, or a prosthesis, which of the following is shown to be true? So what they are asking is which statement is true. When there is a space and you're maintaining it without a replacement, so what can happen, basically they are asking. Well, moderately shortened dental arches had little impact on occlusal stability. Tooth loading, TMJ disorders, interdental spacing, periodontal disease, patient comfort, or masticated performance. Okay, loss of a single posterior tooth creating an interrupted dental arch or bounded posterior space had significant effect of shifting, decrease in alveolar support, or loss of adjacent teeth. That's the correct. So basically what this option says is that, for example, in the posterior area, 6, 7, 8 were there, teeth, and you extracted 7. So what will happen? The alveolar bone around the region of the 7 is going to dip like a semilunar shape. 6 and 8 will get tilted. The opposing tooth 6 is going to get supra erupted. That is what this option means, and that is a true option. Provision of a fixed partial denture was associated with modestly improved survival rate of the adjacent teeth. There is no study which states that, but I wouldn't say the statement is wrong. It probably would be correct. But the more correct option is option B. Because the question asked what you would do, what do you expect in the edentulous space when you don't give a replacement, and option C says you have given a replacement. You understand? Hence, I would go with option B. Loss of teeth had considerable psychosocial impact. Well, it all depends on patient to patient. Not everybody has a psychosocial impact. Hence, I won't go with this option. I don't know why the candidate chose this option. It's pretty obvious that the option is B. But anyways, a recent systematic review comparing the clinical outcomes of restored endodontically treated teeth with those of implant-supported restorations concluded that, so the question is asking, there was a review in which they compared the outcomes of root canal treated teeth compared with the teeth which were extracted and implant was placed in that area. So basically they are saying, is it what is the comparison, what is the review that came out when you compared teeth which could be saved by root canal or teeth which were extracted and then an implant was placed in place of that, basically to do root canal or not. So the decision to treat the tooth endodontically or replace it with an implant must be based on factors other than the treatment outcomes of the procedure themselves. So that is what the review came. Now what does that mean? It means that when you choose to do root canal in a tooth, you should give preference whether you can finally be able to restore the tooth and not based upon the pathology as to why you're doing a root canal, will it be success or not. For example, there is a little complex root anatomy. So what this question is saying, that you should not think whether or not your root canal treatment would be successful. You should think whether after the root canal treatment, be it successful or not, you are able to put a proper crown or do a proper restoration. And then you compare it to the implant. So your decision to do root canal or implant should not be based upon the anatomy of the roots or your skills. It should be based on the fact whether the tooth can be restored or not. That is what the systematic review is saying. I know it sounds a bit complex, but if you read the other options, you will realize that this option is way better than all the other options. You are coming to SBQ 13, you are deciding on the best type of prosthetic replacement for the following patient. Okay, best type, that is what it's saying. So that means all the sub-question options would be correct. And you have to decide which is the best one. So first, a 40-year-old patient with generalized periodontal disease and some pocket depths are up to 5 mm. So what would you give? See, when there is a generalized periodontal disease, you want to give an acrylic denture. Why? Because more teeth can fall off, more teeth can be extracted because there is a periodontal disease going on. And in an acrylic denture, it's easier to add a tooth. In cobalt chromium denture, it's very difficult to add a tooth if something has fallen off. Plus, an acrylic denture would be more suitable when there is a generalized periodontal disease going on. In cobalt chromium, it's better if you have a healthy mouth and no periodontal disease. Then a young female present with high lip line, okay, looking for replacement of her upper mist incisor. So when there is a high lip line, meaning if you give a fixed bridge to her, the gaps between the gum and the bridge can be seen in acrylic denture in a young female. Doesn't, it would create a social impact. Here, the main scenario question is not what the patient wants. Here, the main scenario question is what is the best replacement option in such patients. So here you don't have to see the financial condition. You have to see what is the best, what is the ideal thing in this case. Then we will move on as to what the patient wants or not. So when there is a young female, that means everything is very healthy, then implant becomes an option of choice. Correct? Next, a 50-year-old patient who does not want heavy denture and has nickel sensitivity. So here you could have chosen the answer acrylic, but when the option is given as a flexible dentures are lighter than the acrylic, and specifically the question is mentioning he doesn't want a heavy denture. So your answer becomes flexible denture. Patient who lost right and left lower posterior teeth for 10 years. So which classification is that? Kennedy's class 1. Looking for an affordable replacement. Affordable means what? Acrylic denture. Here again you can say flexible denture, but when both the posterior teeth are missing, it's better to go with a sturdy acrylic denture. Flexible denture is not going to give that kind of support when bilateral saddle cases are there. Understood? So you have to think. Do you see that almost all the options are same in all the questions? Fixed denture, implant, acrylic, flexible. But because they change the question, your answer changes. This is how you're supposed to analyze each and every ADC question. Young patient with unilateral edentulous space. Okay, unilateral edentulous space means Kennedy's classification 2. Bounded by teeth with good periodontal support. Okay. So in this scenario, what the question is saying, there's an edentulous space. So again, I just read unilateral edentulous space and I said Kennedy's classification 2. But then the question is also saying it's bounded by teeth with good periodontal support. Bounded by teeth means there is anterior and posterior teeth are present. So now it becomes which Kennedy's classification? It becomes Kennedy's classification 3, where there is an edentulous space but anteriorly and posteriorly teeth are present. Like for example, 5 and 6 are missing, but 4 and 7, 8 are present. So, and there is good support. So here, because the option of implant is not given, I'm going to go with fixed partial denture. That's a bridge. Why do you want to give a removable one? Because it's a removable, it's a young patient, so might as well give some fixed option. Implant would have been the ideal one, but the option is not given. If the option of implant was given, I would have chosen that. Understood? Now we come back, we move forward to case 14. So the last SBQ, case 14, a 60-year-old edentulous female reported to the College of Dental Surgery with a chief complaint of loss of denture retention. There is loss of denture retention, okay? She presented with soft tissue overgrowth. She had the habit of cigarette smoking since her 20s and she's 60, so 40 years of smoking. On clinical examination, a pedunculated creamish white lesion with finger-like projections on its surface measuring 5 by 3 millimeters in greatest dimension was observed like this. On palpation, the growth was non-tender, meaning it was firm in consistency and it was painless. Understood? It's a painless with a finger-like projection. So it's probably a cancerous growth as she has been smoking for past 40 years. So what is your management? Tell the patient that a biopsy is needed because this is a very, dangerous kind of lesion. So a biopsy is needed, and for that, if the option was also there, refer to a specialist for biopsy, that would have been your answer of choice. The specimen showed hyperparakeratinized striated squamous epithelium forming papillary projections with connective tissue core in between. The epithelial cells showed vesicular nuclei with prominent nucleoli. What it could be? It has to be a papilloma. It's a papillary projection. Okay, it cannot be adenoma. It is not a fibrous projection, so it is not a fibroma. It's definitely not a lipoma. It's a papilloma. What is the significance? It's a precancerous condition. That is the significance. You should pause this video, go and read about more precancerous lesions present in the mouth because any one of them can be asked. What is the best treatment? Well, you have to excise it. What could be the reason of the papilloma? It's HPV, human papilloma virus. Understood? So again, pause the video, go and read about HPV. Pretty straightforward questions. If you can recognize the lesion, then all the sub questions are based exactly on it, you know. So there it is. We finished all the questions for paper 2, that is mock 13. My suggestion is again solve this mock. Now this time try to analyze the question. Imagine the scenarios, imagine the images in your head when you're reading the question so that you filter it and you're able to mark the sub-questions quickly because time is very, very important when you're attempting your ADC exam. So for all the new candidates who would like to, get more of such videos, you can get enrolled or you can wait when I post these videos on my YouTube and my Facebook group. It would be once or twice a month, but the enrolled candidates get all the links of the videos immediately. Alright, so if any question is there regarding this mock, please feel free to email me and I'll answer your doubt. So have a good day. Bye-bye.